Welcome to the Scientific Sense podcast, where we explore emerging ideas from science, policy, economics, and technology. My name is Gill Eapen. We talk with world's leading academics and experts about their recent research or general areas of topical interest. Scientific Sense is an unstructured conversation with no agenda or preparation. We cover a wide variety of domains where new discoveries are made and new technologies are developed on a daily basis. We are most interested in how new ideas affect society and help educate the world how to pursue a rewarding and enjoyable life rooted in science, logic, and information. We seek knowledge without boundaries or constraints and provide unedited content of conversations with researchers and leaders who love what they do. A companion blog to this podcast can be found at scientificsense.com, and this podcast is available on over a dozen platforms and directly at scientificsense.net. If you have suggestions for topics, guests, and other ideas, please send them to info@scientificsense.com, and I can be reached at gill@eapen.info. My guest today is Dr. Deepa HalaHarvi, who is a breast cancer surgeon at Ohio Health and a breast cancer survivor. She is also Associate Program Director for the Breast Surgery Fellowship at Grant Medical Center. She has also started a survivorship series lectures at Ohio Health for cancer survivors. Welcome, Deepa.
Thank you so much, Gil, for having me today.
Absolutely, yeah. So I want to start with there are a few articles that I would love to dig a little deeper into. So one of the articles, I think, a colleague of yours from University of Michigan, entitled "Disparities in Breast Cancer and African Ancestry: A Global Perspective," and in which she says recognition of breast cancer disparities between African American and white American women has generated exciting research opportunities investigating the biologic and hereditary factors that contribute to the observed outcome differences, leading to international studies of breast cancer in Africa. You want to talk a bit about the outcome differences that we see in the US and perhaps more generally internationally?
Yeah, so this is the topic of my interest, and I have been reading a lot about it. And so in African Americans, I think when they're diagnosed, they tend to be diagnosed more with an advanced stage of breast cancer versus like Caucasian women tend to get diagnosed with more regional disease. In fact, the numbers that are quoted are for Caucasian women, they're diagnosed with local disease about 64% of the time, whereas African Americans are diagnosed only 54% of the time they're diagnosed with local disease. It's more spread to regional disease when they're diagnosed. There's a number of factors that is associated with this.
So local disease, local disease meaning it's sort of early in
yes,
its progression?
Okay. Meaning the disease just to the breast.
Yeah.
And when we say local regional disease, now disease has spread not just to the breast, but also to the lymph nodes.
Okay.
And so that, can be in a higher stage when they're diagnosed.
Right.
And so it requires more treatments for them. The other factors that we've seen in African Americans, obviously like socioeconomic factors, access to healthcare, but more also comorbidities such as diabetes and obesity.
Yeah.
They also tend to be, there's also biological differences in the cancer that is diagnosed in African Americans, such as triple negative breast cancer, that tends to not have as good of a survival rates compared to non-triple negative breast cancer. Maybe the problems. Sorry, go ahead.
No. So I was looking at. In the article, she says the impact of breast cancer on African American compared to white American Caucasian women is characterized by a complex and seemingly paradoxical differences. And I think this is what you're talking about. So with lifetime incidence rates being lower in African Americans, but they have a higher mortality rate, right? Higher case mortality rates.
That is correct. Yeah. So, and I think a lot of things, I think they do have, more triple negative breast cancer, and they also tend to get diagnosed with breast cancer at younger ages. And so, and also there's thought that they don't follow up right after they have an abnormal mammography for like biopsies and further imaging. Perhaps, access to finding good high quality healthcare also could be a problem. And maybe going to, to facilities that is not accredited. And in general, triple negative breast cancer, the prognosis is not as great as, what we call luminal A breast cancer, which is hormone receptor positive and HER2 receptor negative breast cancer.
So triple negative breast cancer, at the highest level, it doesn't really respond to the typical therapies that are available, right? Is that the issue?
Yeah. So, so if you compare a triple negative breast cancer to, say, a luminal A breast cancer, which is hormone receptor positive breast cancer, so the options are they can get chemotherapy depending on how big is the cancer, is the cancer invaded the lymph nodes? There's a number of different factors that goes into, getting chemotherapy. And then after they're done with their surgical management, the chemotherapy, radiation, depending on what kind of surgery they're doing, they also will get endocrine therapy. That's the estrogen blockers to block the hormone receptors. In triple negative breast cancer, unfortunately, you don't have those receptors on the cell. So I kind of describe it as a naked cell to my patients. So triple negative breast cancer does not have the hormone receptors. So really the only option for them is chemotherapy. And so if the chemotherapy does not work well, then, it's, they are not going to do well with it.
Is it, so that is genetic, right?
So, and that's also another thing from reading all these articles that I'm finding out is, BRCA1, the mutation BRCA1 is more predominantly associated with triple negative breast cancers. And we're also finding out that there's a lot of the mutation of BRCA found in African Americans that we did not know about in the past.
So that's interesting. So that has implications, and I think we'll talk about this both in terms of the timing of screening and what type of screening, right? But before we get to that, I was looking at this chart in this paper, Deepa, that, so it has the incidence rates and mortality rates.
Yes.
And, it has data for developed regions, less developed regions, Western Europe, and so on, and then different sections of Africa. And one of the surprising things to me is, granted, the incidence rates are lower in many parts of Africa, and that could be just screening modalities or screening frequency, perhaps, right? We're not picking them up.
Yes.
But the mortality rates appear to be, I guess, in comparison to incidence rate is high, but it is in general not that different from, let's say, other less developed regions, for example. And so if I guess, let me ask it differently. Do we have any hypothesis as to African American women having higher triple negative breast cancer and higher BRCA1 mutations, and hence we should find a higher mortality rate, right? So in other words, do we find a difference between African American population in the US compared to in Africa?
Yeah, actually in the US, one of the papers I was reading, actually it's from American Cancer Society. It quotes a 5-year survival rate for African Americans to be 81% versus 91% for the Caucasian women. So there is a disparity in the survival rates, and most of that is attributed to the triple negative breast cancer. Now, whether that's associated with BRCA or not, we don't know. Yeah. But just the fact that the biology of the cancer that they're diagnosed with, the higher grade and the triple negative, and it's not just local disease, but local regional, so higher stage when they're diagnosed. And we don't know if they're following up with the treatments, if they're compliant with the treatments. That's another factor. So I think it's multifactorial as to why that is. Definitely biology plays a huge role in it for sure.
Right. Yeah. And then there is the question of when do you detect it and like you say, follow up and all of that. So the earliest detectable form of breast cancer is the ductal carcinoma in situ, DCIS.
That is
And do we see a difference in DCIS occurrences between African American and Caucasian women?
I think the incidence rate is the same. I think so. The DCIS is a non-palpable cancer, so most commonly it's seen on a screening mammography. So it's not something women can feel. So the disparity does come in whether women are following through with the screening mammography, which again, there is a confusion between this different guidelines for screening mammograms. We have different associations, talking about starting age at a different times. For example, American Cancer Society does not recommend a screening mammogram till age 45. They say between age 40 and 44, informed decision making with the healthcare provider. And then 45 to 54, they recommend a screening mammogram every year. Then after 55, it's every year or every other year. Now, National Comprehensive Cancer Network, they do recommend mammography starting at age 40 and every year for as long as woman is in good health. Then there is the U.S. Preventative Service Task Force. They say, again, between 40 to 49, informed decision-making with healthcare provider. And then after, ages 50 to 74, they recommend it every other year. So I think there is so much confusion in when one should get screening mammograms. DCIS is diagnosed typically on a screening mammography. And so if a woman is not following through and getting their screening, you're not going to be able to diagnose the early stage cancer. That's one thing. The other thing is African Americans tend to have triple negative cancers in younger age women. So that's, between ages 40 to 50, and we tend to diagnose them with triple negative breast cancer. So again, if they're not following up with the guidelines and going and getting mammography every year starting at age 40, then that's a problem also.
Right. Yeah. So I see that in November 2009, when United States Preventative Services Task Force had recommendations, they had a blanket recommendation that initiating screening for everybody at age 50. And I guess they changed it since then. But what you're saying also is that since we find TNBC incidence rates to be different in different demographics, you probably need different. The screening should start at different ages, perhaps, right?
That is correct. Well, so for sure, we know the studies have shown, there's a recent study that came out in Lancet. It's a randomized control study. It's actually a British study that looked at several thousand women and 160,000 women, 160,921 women between 1990 to 1997. It's a follow-up of almost 23 years. They actually found breast cancer mortality reduction if you start mammography at 40. And it really doesn't, you don't actually start seeing the reduction at least till 10 years after you started doing your mammography. And they do specifically talk about African-American women and, especially because they tend to have triple negative breast cancer at such a younger age.
Yeah, so let me ask you this, Deba. If there are differences in incidence rates across the states in the U.S., I believe Connecticut, for example, where I live, has one of the highest incidence rates of breast cancer. One could attribute that to higher levels of screening. In which case, I would imagine, I'm just making this hypothesis, you can let me know if this is true, then you would think that you are picking up a larger number of people at very early stage. So you should actually see case mortality drop if you have higher levels of screening and higher incidence rates, if incidence rates are related to higher screening, right?
That is correct. And also, if you're catching women at early stage breast cancer, their survival and prognosis is way different. So for example, like you alluded to DCIS, which is a stage 0 breast cancer, And so the options are, obviously surgery is an option. They can have lesser surgery such as a lumpectomy or what's called a partial mastectomy, and they can still preserve breasts. And they may or may not need radiation. We have, genomic tests that will tell us if radiation is beneficial for them. So maybe all they need is a surgery and then endocrine therapy. That's an option.
Right.
For women who are diagnosed with early stage cancer, they may just need a lumpectomy, radiation, endocrine therapy, may not even need chemotherapy. And so definitely the survival rate is much higher if women are diagnosed in early stage versus women diagnosed in later stages. So that there is definitely correlation to that.
Yeah. Let me go into another paper: breast cancer mortality in African American and non-Hispanic white women by molecular subtype and stage at diagnosis. It's a population-based study. So higher breast cancer mortality rates for African American than non-Hispanic white women are well documented, the paper says. However, it remains uncertain if this disparity occurs in disease subgroups defined by tumor molecular markers and stage at diagnosis. There are some sort of counterintuitive results here. You want to talk a bit about that?
Which paper are you talking about?
So this is breast cancer mortality in African American and non-Hispanic white women by molecular subtype and stage at diagnosis. So one of the things I noticed in the paper is that there is a difference in stage 1 and stage 4, but not in stage 2 and stage 3, or the other way around. And so I wondered what's causing that. So they say that in this paper, they say that after adjustment for patient tumor and treatment characteristics, outcomes were comparable by race for stage 1 or 4 cancer, regardless of subtype. But they find substantially higher hazards of breast cancer death among African American women in stage 2 and stage 3. So in other words, it's sort of a U-shaped type outcome, not outcome, but difference between African American and white women.
Yeah, I think one of the things that they talk about in this paper is early detection and early diagnosis to eliminate the disparities, which is consistent with what we saw in the past. Right. And also, I think stage 3, they talk about a lot of it is triple negative breast cancer.
Okay.
That's what makes the difference, is I think, believe what they're talking about in this paper.
Okay, so is it true, Deepa, that if you have triple negative breast cancer or BRCA mutations, you generally tend to get to stage 2 before you are diagnosed? Is that true or not?
So so triple negative breast cancer. So really staging takes into account the size of the tumor, the grade of the tumor, the hormone receptor status, and so those are all the things that go into staging. So really it depends on when the person is diagnosed with and triple negatives tend to be a little bit higher stage versus the same size. For their hormone receptor positive tends to be lower stage. This is the newest AJCCC 8th edition staging system. The triple negatives tends to be a little higher stage. Again, it all really depends on the size of the tumor and the grade of the tumor.
So TNBC tends to progress faster too?
Yes, it does. Yeah, it can progress faster, and it tends to be heterogeneous. There are so many subtypes in TNBC, and I think that's really what makes it difficult to treat it. So if you're not treating the correct subtype, you may not actually be treating the right kind of triple negative cancer, and sometimes that's a trial and an error. We won't know until the cancer reoccurs. And the risk of cancer reoccurring for triple negatives is also, higher in the first 5 years of the diagnosis.
Right. Okay. There's another paper here, which is along the same lines: effect of mammographic screening from age 40 years on breast cancer mortality. This is a UK study.
Yes, that's the one I was alluding to earlier.
Okay. And again, they're finding that we aim to estimate the effect of mammographic screening at ages 40 to 48 years on breast cancer mortality. The standard was 50. It subsequently was reduced to 45. Is that right? And what they're finding is that even going lower is beneficial, or starting early is beneficial.
Yeah, so I think they say it should be reduced to starting from 50 to 40 years. That can, potentially reduce breast cancer mortality. This is something, screening mammography has been so well studied. We have 8 randomized studies that have looked at screening mammography. And I usually tell patients we really don't have those many randomized studies for like colonoscopy or any other modality that we have for mammography. So I don't think we need to go back to reinvent the wheel. We know mammography reduces the mortality, and this paper is really good. It's not American study, it's UK, from UK, but they talk about reducing the age limit from 50 to 40 and talking about decreasing the mortality, breast cancer associated mortality. The problem, though, and some of the organizations will argue that younger women tend to have dense breast tissue. So mammograms may or may not be the best modality for them. Right. And the other thing too is
it ultrasound then that might be better?
So we went from a traditional 2D mammography to 3D mammography. Yeah. So that's essentially like a CT scan where it can look at the slices of the breast, and so instead of giving you 2 views, it gives you a number of different views. So it does pick up more cancer. The 3D mammography does. The ultrasound is another option, especially if a woman or a physician is feeling a mass. That's an option. Now, for women that's for average risk women. For women who are high risk, meaning if they have family history of breast cancer, there are these risk models that we calculate sometimes based on their family history. If they are lifetime risk of more than 20% risk of getting breast cancer, then they also have an option of an MRI as well as a mammography. So MRI is more sensitive compared to a mammogram, and you can alternate. I typically alternate a mammogram and an MRI to catch those interval cancers. And also these women tend to be younger women. So there is a risk of, false positives. And so you do have to worry about that just because MRI is so sensitive.
Right. So is both mammogram and MRI, are they superior to ultrasound in general?
So, ultrasound really is very operator dependent. So really the technician dependent. So someone who does the ultrasounds very frequently is really good at them. And then the rate of false positives goes down. But if someone does not, is not a good at using an ultrasound, you can really have a number of unnecessary biopsies. So there is a place for an ultrasound, especially if a patient is feeling a mass or, we are palpating a mass in the office, then there's definitely a place for an ultrasound. But really, it's not embraced as well as a mammogram. And like I said earlier, mammogram is really well-studied modality.
Yeah, I don't know much about this, Deepa, but, the public might look at mammogram as, some level of radiation, whereas ultrasound is not. So is there a situation that ultrasound could be used as kind of an early screen, and then if you find if you are unsure, then go to or is it that the radiation levels associated with mammogram is really irrelevant in this decision?
Yeah, the radiation you receive from mammography is really not that high. Yeah. You get more radiation, going in an airplane, say from New York to California, than you get in the mammography. So, and when women talk about it, we typically, if you put it in that perspective, they understand it better. But it's really not that much more radiation than people really think. In your surroundings, you probably get more radiation than you get, with the mammography.
And so mammography is really the standard of care. And generally speaking, earlier screening appears to be very beneficial.
Correct.
And more generally, people who are at a higher risk category, demographics at a higher risk category, may want to have that started early, right? That's the standard of care.
That is correct. Yes. Yeah, absolutely. So in average risk women, meaning really women do not have as many family members who've had breast cancer. We typically at Ohio Health tend to start mammography at age 40, and that's what NCCN recommended. And we're also MD Anderson certified. I'm also MD Anderson certified physician and network. They also recommend the same thing as starting mammography at age 40 for an average risk woman. Women who is high risk is typically, you do those risk models, either Gale risk or Tyrer-Cuzick or BRCA Pro. And if the lifetime risk is greater than 20%, then we do recommend imaging and mammography alternating with an MRI, as well as 2 breast exams in a year by 2 clinicians and a self-breast exam every month. And it's basically called self-breast awareness. They don't call it an exam, but it's more an awareness. But I think women need to be aware of their breast and, feeling for any lumps or masses that feel worrisome, and also feeling there underneath the arms to make sure there's no enlarged lymph nodes.
Right. I want to touch on another issue, which is equally problematic, and that is disparities in breast cancer surgery delay, the lingering effect of race. Paper says delays to surgical breast cancer treatment of 90 days or more may be associated with greater stage migration, and they investigate racial disparities in time to receiving first surgical treatment in breast cancer patients to actual surgery.
So I'm in generally, like in our institution, we really, try to get a patient from diagnosis to surgery within 6 weeks. So, I think a number of things that this paper listed that could be the reasons is perhaps the patient did not want to go through surgery, maybe transportation problems, just following up problems. But I mean, definitely if there is delay in more than 90 days, that definitely does not lead to good prognosis. And obviously breast cancer it's typically takes months for the cell to divide and multiply. But again, you don't want to delay it more than 90 days for sure.
Yeah, I mean, that's an amazing thing, right? So the more you wait, the higher the risk that you can recover from it. It's almost like once you have a diagnosis, you have to almost immediately get some kind of a process working already.
Right. Yeah, exactly. And so, I mean, there's 2 things. So when a patient gets diagnosed, we try to expedite if they need additional imaging, additional biopsies. And sometimes patients get really anxious about it. Why are you doing it so quickly? Am I going to die tomorrow? Well, not really. You're not going to die tomorrow. We just want to expedite the process so we can get you to surgery or the, treatment that's, that needs to happen next. But at the same time, you don't want to delay it, because it does have, worse prognosis.
Right. Yeah, I want to go into another paper. This is your paper with others. Prophylactic mastectomy can save patients up to 50,000 compared to lifelong screening in BRCA and BRCA1 and BRCA2 patients. So you say awareness of value-based quality care has become an increasingly important issue for healthcare. And patients with BRCA mutations have a lifetime risk of developing breast cancer up to 87% by age 70.
Yes.
So that is an incredible number. I remember there was an actress, I can remember her name. She opted for who is that?
Jolie. Is it Angelina Jolie?
Angelina, yeah, okay, yeah. And so so this seems like it's becoming sort of a standard of care, right? If you find that mutation, that's probably the best thing one could do.
Well, so, I mean, women have options. And I think our job is, we do what's called shared decision making. So my job as a physician and a surgeon is to explain to women. So say you have BRCA mutation, your lifetime risk of breast cancer is 87%. Your lifetime risk of ovarian cancer is 40%. Mm-hmm. So there's recommendations by NCCN. And so obviously prophylactic mastectomy is a recommendation. A prophylactic oophorectomy is also a recommendation, between ages 35 to 40 for a BRCA1 and 40 to 45 BRCA2. When a woman has a prophylactic mastectomy, the risk reduction is up, 90% of risk reduction of breast cancer. 95% of the women had oophorectomy or removal of her ovaries. Now they have options. They don't have to choose the prophylactic mastectomy. The option is to follow them more closely with an MRI and mammography. And I think ultimately it's the woman's choice as to what she wants to do. Our job is to make sure educate them the different options. I'll tell you honestly, for these women, who come in, who have a mammogram and 6 months later they have an MRI and there's something that's found, they need a biopsy and then we call them with results. It really all happens very quickly. But, as I'm also a breast cancer survivor, just waiting to get those results, not knowing if they're going to get a call saying it's cancer or it's benign, that wait just seems to be really, really long. And so sometimes women just want to do a prophylactic mastectomy because they just don't want to keep going through these biopsies and imaging every 6 months. And also for women who've had cancer, every time they go to get imaging, it's almost like PTSD, they have to relive that experience again. So bottom line is it's a woman's decision and our job is to help them with those decisions.
Yeah, so prophylactic here means that you're basically opting to essentially remove the breast before any diagnosis, right? So yeah.
That is correct. Prophylactic mastectomy means removing the breast tissue before the diagnosis of cancer. And, and women can opt for no reconstruction or immediate reconstruction or delayed reconstruction. And most of these women that we looked at here opted for immediate reconstruction.
Right. And the BRCA1 and BRCA2, that can be identified by a simple blood test?
Yes, blood test. And nowadays we're doing just a spit test because of COVID. Right. It's just a spit test these days, just looking at the DNA.
So there is no reason not to do it, right? Why wouldn't you do it like when you are 10? I mean, why wait for?
Yeah. So the recommendations are, one needs to turn 18, but there's, several criteria for which one is eligible for this testing, genetic testing. Yeah. For instance, if a woman is younger than 50 and she's diagnosed with breast cancer, she qualifies at least for counseling. That's different than testing. Counseling, the counselor will talk to them about the family history, and if she would qualify for testing, they would go ahead and test her. There's also, also the other criteria is if you're older than 50, then you have to have at least 2 family members with breast cancer, family history of ovarian cancer, or family history of pancreatic cancer. There's a number of different criteria by NCCN. And so if my mother had BRCA 1 or 2, I would be eligible for testing at 18. And not before 18, because you're really not doing anything different before then. You help them for, do a breast exam and starting at age 18, but you really don't even get any sort of imaging till age 25. And that's an MRI is recommended between ages 25 to 30. And then starting at age 30, a mammography every year, along with self-breast exam and 2 exams by clinicians every year.
Okay. Yeah. So in conclusion, Deepa, when you look forward, what are the technologies and kind of treatment modalities do you believe will change? What are the things that you're most excited about in this arena?
So, I'm a surgeon, so I would have to say I'm very excited about surgery. So I perform not just traditional simple mastectomies, which is removing the breast tissue, the nipple areolar complex, but we also perform nipple sparing mastectomies where we preserve the nipple areolar complex and we hide the incision. So hidden scar surgery, that's another new upcoming thing where we hide incisions either in the inframammary fold or the bra line or underneath the arms where women don't see these scars. These scars are typically a reminder of cancer and what a woman has gone through. So, that's exciting. Nipple sparing mastectomy is really, we're doing a lot of them these days. There's also what's called nipple delay technique, essentially for these women who have large breasts and ptotic breasts, meaning like breasts that are a little bit drooping and large, breasts. Typically, nipple sparing mastectomy was not an option. Now we take them to surgery 2 weeks prior to their mastectomies and remove the tissue underneath the nipple areolar complex to sort of challenge the blood supply to the nipple areolar complex. And then 2 weeks later, we take them back to do a nipple sparing mastectomy. This just, greater likelihood of preserving that nipple areolar complex for women. And, body image is a big deal. I deal with a lot of young women. I mean, my youngest woman that I've diagnosed is 25. So they have several years to live. And so I don't want the incisions or the scars to be a reminder of cancer.
Right. Yeah, as a surgeon, I need to ask you this also, Deepa. There's a lot of excitement in other industries about robotics, artificial intelligence, and so on. Do you see do you see those technologies becoming good enough to perhaps not completely take over from a surgeon, but in with the guidance of surgeon, do much of the work?
Yeah, the robotics, I actually, watched a video at our conference last year, and it just doesn't seem like practical application. I feel like takes a long time. And, and also there's something to say about feeling the tissue. You're going to miss out on actually feeling the tissue because you're not actually using your hands to feel the tissue. So I don't know if that's going to take over here as much. Artificial intelligence, I did, I attended the Linsage conference virtually this year, and they did talk about it a little bit. There are places that I think it's going to adapt and take over, like, mammography could be read, by artificial intelligence. But also ultimately, we just don't have enough data yet. Is that going to lead to more biopsies, which leads to more anxiety for women? I think time will tell. I'm not that excited yet. I think using not just looking at the images, but also, there's so much that goes into the treatment of breast cancer.
Yeah.
And my job is exciting because I'm always, not two people have the same treatment. And I think we still have to use our brain and our knowledge and expertise. And typically it's a multidisciplinary conference where we discuss these cases. So, and there's medical oncologists, radiation oncologists, radiologists, surgeons, genetic counselors. And so, it takes a whole team to come together with a good plan. I just don't know how artificial intelligence can take over something like that.
The problem here is, I think, Deva, is that every cancer is different. Cancer affecting every organ is different. Every individual's cancer is different. And every cancer, how it mutates, is different. So typically artificial intelligence works when you have a lot of historical data where you can find fairly robust patterns, right? Whereas here, each incidence is essentially a customized disease for that individual, the way that I understand it.
That is correct. Yeah. This is for breast cancer, it's a very personalized care. Now we have genomic testing, that tells us specifically who needs chemotherapy and who does not need chemotherapy. And so, every patient is different. Every cancer is different, like you said. And so, I think, more to come on that. I think time will tell. But as of right now, I'm not sure that it's going to take over.
Yeah, excellent. Yeah, this has been great, Deva. Thanks so much for doing this late in the evening after the surgeries.
Oh, no, thank you so much for asking me to do it.
Yeah, thanks so much.
Yeah, no, thank you.
Keep safe.
All right, you too. Thank you so much. Have a good evening. Bye.
Bye.